fairly cross-cutting sort of question. So perhaps I'll direct this to you, Azra, first, and then to Neil. Because this question relates to low and middle income settings, but also the potential role of episodic lockdown measures. So essentially the question is, we're looking at potential for episodic lockdown as a response to COVID-19, but also, as we know, contact tracing and test and trace is also a very important tool in the arsenal. So would you suggest, for example, that if a local setting were able to actually implement these episodic lockdowns effectively, that could replace test and trace or contact tracing, or should measures be more textured than that? Perhaps first Azra and then Neil.
Yeah, I think, I mean, from the perspective of some of the lower middle income setting, it's very context dependent. So it does very much depend on understanding how people behave in your local area to be able to understand whether those whether it's more appropriate to have a local lockdown or indeed try and contact trace. So, for example, we've worked very closely on that particular question with the US CDC office in Nigeria. Nigeria has been looking at local lockdowns as one of the core ways of its strategy, and early on they undertook very intensive contact tracing, and that contact tracing capacity was of course in place following the Ebola outbreaks that occurred there, and Nigeria were very good at controlling Ebola, so they were very much on top of this early on in the major cities. But of course, as you go out, the facilities aren't always there in all of the regions. So I think it's a balance between what works, but the most difficult thing about the local lockdowns is the economic ability of the people to survive that. That is challenging for many places and may make it a difficult thing to implement. So yes, it will vary from one setting to another.
Thank you. Neil?
So I would hope, I mean, lockdown isn't a well-defined intervention, and no two countries have implemented it in precisely the same way. I mean, it's really the application of a suite of non-pharmaceutical interventions to control transmission. And I would say test and trace is a complement to that, isolation, quarantining. What it means is local lockdown, whatever that means, can be less intensive. You have less distance to go to suppress transmission if you have effective case isolation and isolation of contacts than you would in its absence. I think the other thing that large-scale testing gives you is the ability to know where transmission is happening, which is perhaps its most valuable benefit. If you rely just on mortality monitoring or hospital monitoring, you're well behind the epidemic curve. And at that point, once hospitals start to show a signal that you start to see a new signal in deaths, you really do have to impose quite drastic measures to get on top of transmission. Whilst if you're monitoring, as we are now across Europe, and actually many, I think in India, there's a lot of testing in some areas at least, you do get a much better sense of where transmission is happening, and you can target your measures in a more timely and geographically focused way.
Great, thank you very much. So the next question is one for Gabriel. This is on the different tests available for COVID-19. So Anonymous asks, please could you tell us more about the reliability of antibody serology rapid test kits compared to RT-PCR for confirmation of infected people?
Well, I think that RT-PCR remains the gold standard, but then even within RT-PCR testing, you have different variations. So whether you pull samples, how you actually organize it to be efficient. And there are, in fact, I recently read an Israeli paper actually looking at clever permutations and combinations and trying to make sure that it is the most efficiently done. But it's expensive, and it oftentimes is plagued by bottlenecks, mostly logistically and not really in the laboratory itself. Also, sampling. So depending on what type of samples, whether it's true nasopharyngeal samples versus nasal swabs versus throat swabs versus combined nasal and throat swabs versus what we call deep throat salivary samples or posterior oropharyngeal saliva samples, I think they all affect sensitivity and specificity. But what I would not recommend is to use acute phase IgM, which mostly you would find in fairly cheap and readily available lateral flow tests, almost like the pregnancy stick. I don't think that those are reliable because they capture, even for IgM, relatively later than the RT-PCR. And given the infectiousness profile, inferring from the shedding profile of COVID-19, by the time you actually spike your IgM, let alone your IgG, you're probably over your peak shedding, and therefore it's not very much use. And there are cheaper alternatives to the RT-PCR, like antigen testing, and we've read in the mass media reports of fairly cheap, around about $4 or $5 per test of antigen tests. And so I think that may, if you actually compensate the lack of sensitivity of these antigen tests by increased frequency, because it is much cheaper and it's much more widely available, you might be able to compensate that. But I still think that we have to be very, very careful and know exactly what we're testing for and what is the purpose of that testing. Is it to get a general idea of surveillance in terms of monitoring where the population is, or is it for diagnostic purposes? Or what I suspect we will find a lot more of is in terms of the so-called green corridors or travel bubbles that you will see being much more talked about as we now move ahead into the fourth quarter of the year.
Great. Thank you, Gabriel. And a question for Azra, but this is from Penny Hancock. Penny asked the question in the context of Nigeria, but I think this actually applies much more broadly, which is about whether deaths are underreported in, let's say, Nigeria and many of the other settings that you've considered, and how do models account for underreporting of deaths?
Yes, thanks, Penny. Yes, deaths are certainly underreported. I think we know deaths are underreported everywhere because the deaths that certainly reported in the UK early on were an underreport once the final statistics came through death registration. So we know that it's an underreport. I think the difficulty is knowing the extent of the underreport in one setting versus another setting, and indeed even within a country. So, for example, in Nigeria, we think the death reporting is probably quite good in Lagos and Abuja, but is much, much worse in other areas of that country. And I think that will be replicated in many areas. We're working with a couple of different country partners to explore this in more detail. One of our PhD students, Azra, is working in Indonesia, looking at funeral data. And funeral data spiked at a much higher level than the reported deaths, so that gives us some estimate then of the true reporting. Similarly, we have some work hopefully coming out this week on looking at Syria, with colleagues in Syria, looking at death reporting compared to other metrics there, and that does suggest, obviously, in somewhere like Syria and the war-torn countries in that region, that death reporting will be very, very low in comparison. And there were some interesting patterns coming out from that. In particular, we're trying to better understand why the epidemic appears to have peaked in some parts of the world. Pakistan's another interesting country from that perspective. Certainly appears to have peaked without having done anything different. So without movement patterns necessarily changing, there seems to have been a decline. And the question is whether actually infection has been so widely spread that there is the evidence of moving towards some herd immunity. And I think that's an interesting area to explore going forwards.
Absolutely. Thank you, Azra. So here is a two-part question, and perhaps I'll direct the first of these to Gabriel and the second to Neil. But this is about important heterogeneities in the transmission of SARS-CoV-2, namely on, and we know that there's a lot of asymptomatic infection, but we also know about the potential for super spreading or heterogeneity in transmission. So could you perhaps talk us through what is known about both of these at the moment, but also how we deal with these in mathematical modeling of SARS-CoV-2? So Gabriel, perhaps if I could ask you to handle the asymptomatic infection, and Neil, the super spreading. Gabriel? Oh, Gabriel, I think you're muted.
Sorry, I'm not sure that
Great.
we understand very much about the asymptomatic infections, simply because even if you have serology data, you would only know these in the aggregate. You would know probably what the proportion of the asymptomatics, you could guess at what they might be using various methods, but you can't really get a handle on individual data as to who might have been asymptomatic and who might not have been, except for when you have very, very good contact tracing and then a complete line list of case contact data. That's when you would actually know. And usually when you have a raging outbreak, even the best infrastructure in contact tracing would be overwhelmed and you would simply have nothing. And usually where you get very good data is when you have sort of bursts of outbreak, which gives you sufficient data, but not so much that it completely overwhelms your tracing ability. For the other data about super spreading, I think it's really looking at the clumpiness, which of course it's over dispersion. And if you look at the clumpiness, my comment would be yes, there is. I think a couple of papers from us and from the London School looking at this whole phenomenon of clustering. And you could, if you believe those estimates, somewhere between 10 to 20% of primary cases actually give rise to 80% of transmission. And that really sort of goes to the clumpiness issue. As far as the public health implication goes, I think it goes to, look, because 60–70% of primaries or index cases don't actually give rise to any secondaries. So you need to focus your efforts on the 20–30% who actually give you most of the cases. Now, the biggest question is, how do you find these 20–30% of the indexes? And I think rather than focusing on the individuals themselves, not to dismiss the potential of actually super spreaders as opposed to super spreading events, it's much better to actually focus on very high risk settings where you would actually find very large clusters. And very large clusters ad infinitum is super spreading. And we see it with actually a lot of coronaviruses. My last comment would be a very strong caveat of ascertainment bias. Clumpiness actually is much more detectable than individual singleton cases, which don't pass on. So the mere fact that you are actually observing a lot of clumpiness is probably, at least in part, and I don't know how large the part is yet, a phenomenon of ascertainment or detection bias. Over.
And Neil, some final thoughts from you.
I'll be very quick given we're out of time, but yes, I think Gabriel raises a key point, which is what are the causes of the observed heterogeneity in number of secondary cases? Is it a matter of individual variation in infectiousness? There probably is some of that. Or is it really about contact patterns and context, which is probably most of it? There are a variety of ways in models to do it. It's in some sense easiest in individual-based models, but then you have the challenge of model complexity and parameterization and fitting. And there's been a variety of attempts to do it in simpler model frameworks. It may be more important to think about when it's important. It's important if there are controls which can modify this. You can target particular settings which are demonstrated to be high risk. And it's important in the establishment of new outbreaks. But in a large-scale epidemic, in terms of these sort of things don't affect the overall rate of growth of the epidemic. They can kind of average out in the wash.
Fantastic, great. Well, I was hoping to use Chair's prerogative to ask a question, but I think I'll have to wait until tomorrow. But it just remains for me to thank all of the speakers in today's session. I really very much enjoyed all of these insights, and I hope you, the audience, have enjoyed it as well. And please do join us tomorrow for our second installment in this webinar series as well. But with that, thank you very much.